The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always.
Attention pediatric healthcare professionals. Are you ready to hear the latest insights on pediatric care? Sort of like you hear on the Virtual Curbside. Join us for the 47th Annual Common Problems in Pediatrics Conference happening June 3rd and 4th, 2025, all virtual. This premier event features expert speakers and cutting-edge topics, all from the comfort of your own home or office. Earn CME and MOC2, connect with colleagues, and elevate your practice. Early bird pricing ends April 4th, so don't wait. Register now at aaputah.org events. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, and we have the great good fortune this month to be able to talk to Kristi Kleinschmit, who's been on the podcast before. Always an interesting and delightful guest. Welcome back, Kristi.
Well, thanks, Paul. I'm so happy to be back this time. Talk about a pretty exciting topic.
Yeah, and some of you who use the call-up line in Utah may have had the great good fortune as well of talking to Kristi. We'll mention the call-up line again at the end, but that really is such a boon to practitioners.
Yeah, no, thanks for bringing that up. Yeah, the call-up line, as a reminder, is a legislatively funded hotline where primary care clinicians can call and talk in real time with a child and adolescent psychiatrist. As well, we just actually launched a new online platform. It is from our website, which will give you the website address, but you can create a profile and you can actually chat in your question, and we can do an asynchronous consult as well. And so if you think of a question you have, but you don't have time to talk to us, you can put it in the portal and we can get back to you with responses and we can have an ongoing conversation.
One of the beauties of that is if anyone else is like me, you get to the end of the conversation, you hang up and you think, oh, wait, I had one more question.
Right, exactly. It can be a chat for as long as you want it to go on. We will just never
brace yourself. This could go on. Well, this month we want to talk about OCD. Do you have anything that you'd like to disclose?
No, I don't have any relevant financial disclosures or any conflicts of interest.
And nothing in your murky past that needs to come up?
No, nothing so exciting as that.
Me either. Safer, less interesting. That's a good thing. Let's talk a little bit about OCD. And first of all, what are the diagnostic criteria for OCD and what is OCD?
Yeah, so OCD, obsessive-compulsive disorder, is a psychiatric disorder that is pretty highly disabling, actually. The criteria, according to the DSM-5, which, was recently revised, didn't change a whole lot, but basically you have either obsessions, which are these thoughts, intrusive, unwanted thoughts, urges or impulses, or sometimes even like flashes or images that come into your brain and are unwanted and intrusive, right? So you're not like trying to think about the thing that is coming into your brain. And then when you get these thoughts or images, you do something to try to decrease them or to prevent something else from happening. So that's the obsessions part. Or you have compulsions, which are these repetitive behaviors. I think that the classic one, right, is hand washing or so like checking things, or like mental acts. And these are the harder ones to get at, but it could be praying, it could be counting, it could be saying things over and over again, silently to yourself. And basically, there's this urge to do these compulsions because it seems like doing it is going to help prevent something awful from happening or to try to manage your obsessions. And so you have obsessions or compulsions or both. And they must be time consuming and interfering with function. And so the amount of time that they say is greater than 1 hour a day of time that you spend doing these things that you cannot do other things. And then certainly not because you're on some sort of a substance or not because of some other psychiatric disorder. And again, just that functional part of it, right? So sometimes you'll see people that have a little bit of this, but they can manage it, or it's not interfering with the amount of time that, they can get to doing other things.
It's a diagnosis that I think is a collection of things that get trivialized in common parlance, right? I'm just a little OCD, which I whistle two fouls for that one. For one, I think that if you define being organized as a disabling thing, I think you've trivialized someone else's problem. But I'm also not really thrilled about the idea of saying I am OCD as opposed to I experience OCD, I have OCD, something like that. I don't know how you feel about that. You see this more often than I do.
Yeah, no, I think both of those are such good points. It is such a disabling diagnosis. And there is the previous obsessive compulsive personality, right? Which is someone who is kind of like rigid and organized. And the thing about that, though, is that it helps them function, right? Like they perform better in the world, right? If you make lists and that's how you keep yourself organized and you have a very tidy house, that feels good to you. And it's sort of egosyntonic is what we say about that is it doesn't cause you distress, right? However, OCD is very, very distressing. It is not comfortable to have this idea that you have to have everything in your house completely organized, or your husband might, or I guess we're talking about kids. So like your mom, something bad might happen to your mom. So I think just trivializing it really makes it hard for the people who actually have OCD to feel like it's something that they have a reasonable permission to feel really distressed about. And then the other thing, right, is I think just like, person first language. I mean, we hate to label anybody with what they are, right? And so, I am OCD, I think just really minimizes all of the other lovely qualities that most of these kids and adolescents have.
I think I've mentioned this on the podcast before, but adolescent me would not have been thrilled about being I'm so acne.
Totally. None of us would be thrilled with that, right?
Now, in preparing for this, there's a OCD personality disorder and then obsessive compulsive disorder. What's the difference between those two things?
Yeah, so OCD, obsessive compulsive personality disorder, is really, so we wouldn't diagnose it in kids. It's sort of like something that we'd, come up with like after the age of 18. But really just kind of like I was saying just a little bit ago, but, really this need to have things like buttoned up and organized and sort of like being kind of rigid and unpredictable is the way that you approach life and the way that you interact with others. And it feels good to you to be like that. And it's not disabling and it doesn't cause dysfunction. It might cause some social difficulties depending what kinds of people that you're around, but it's not the same as this 1 hour a day of like highly distressing compulsions to do things.
And so in my very imperfect understanding of personality disorders, is something that may be more distressing for the people you interact with than for you.
Definitely. Yeah, exactly. It's pretty difficult sometimes, if you have someone who's got OCPD and you're expecting them to go on a last minute vacation with you, or you're expecting them to be a roommate in college with somebody who just could care less about leaving food on the plates, for days at a time. Yeah.
So how common is obsessive compulsive disorder in pediatric patients?
Yeah. So, in general, right, I looked at a couple different sources. I've always thought about 1% is kind of where I've been taught for years, but there's some sources that would say like up to 1 to 4% of people at some point in their lifetime will have a diagnosis of OCD. And if you look at when that actually starts, about 80% of that will be present by the time you're 18 years of age, according to one source. And there's a couple different epidemiological sources, but certainly a quarter by the age of 15. And if you look at boys, it actually presents, the occurrence is about the same between men and women, but it does present earlier in boys than girls. And so about a quarter of boys will have if they're going to have a diagnosis, they'll have their diagnosis by the age of 10, or at least symptoms by the age of 10. They may not actually get diagnosed by then.
And does it cluster in families?
Yes, it's genetically linked. So certainly if you look at like twin studies, looking at recurrence in twins, it's about 0.57 is your concordance rate for monozygotic twins versus 0.22 for dizygotic twins. So a much more highly occurring in identical twins. And then if you have a first degree relative that has OCD, you're about twice as likely to get OCD as someone who doesn't have any relatives with OCD. And if you have a childhood onset OCD, though, so if you're actually having symptoms before the age of 18, your risk of a relative of yours getting OCD is about 10 times. So it is a little more highly genetically linked if it's an earlier presentation.
This is something I'm understanding very imperfectly. So it's OCD is situated with the anxiety disorders, not with the mood disorders. Am I misunderstanding that?
So it used to be considered an anxiety disorder, and now it actually has been clustered on its own, and it's more of this like compulsive disorder
Gotcha.
mix. And so at least the way the DSM has organized it, it's sort of like right next to the anxiety disorders. Because if you've ever worked with someone who has really bad generalized anxiety disorder, let's say, at some point it almost does feel like it's this like obsessiveness of like, if I leave the house, something bad is going to happen to me, so it feels like it's the far end of anxiety. But it's with the other compulsive disorders like skin picking disorder, hair pulling disorder, like trichotillomania. And so they think it's a little more coordinated with those types instead.
Are there predictable comorbidities?
Yeah. I mean, it's high. I mean, just like every other mental health diagnosis we have in kids and adolescents, highly comorbid. So about 50% of kids will have some sort of comorbid diagnosis. If you're younger and it starts, you're more likely to have ADHD or separation anxiety. So those are a little bit more likely to occur with it. Up to 30% of kids who have OCD will have a comorbid tic disorder. Tourette syndrome, right, which is a cluster of having motor tics, multiple motor tics, and one or more vocal tics, often have OCD as a comorbid part of their Tourette disorder as well. So tics certainly up to 30%. And then over your lifetime, almost 3/4 of people who have OCD will end up with another anxiety disorder diagnosis, and about a little over half of them will have some sort of mood disorder.
It feels like obsessive compulsive disorder has some relationship to something like tic disorder, both of them being things that you can potentially suppress, but you can't really.
Yeah, exactly. That compulsive piece, it only can only resist that urge for so long, and then the distress gets high enough that you just have to follow through with it if you don't get some sort of treatment. But I know we'll talk about treatment another time. But yeah, the treatment is fairly similar for tics as well as for OCD.
Well, you'll have to wait till next week. How does the presentation differ in kids and adults?
Yeah. So adults certainly, just with their maturation over time, they do tend to maybe have a little bit more like religious scrupulosity, only because I think, once you get abstract thinking, you have a little bit more, moral
There's more
drive.
to be compulsive about.
Right. And then the other thing, sometimes really unfortunate, intrusive sexual thoughts or thoughts about doing something, illegal or immoral sexually, like that's much more in adults than kids, of course. Kids, especially the younger kids, I think they just have often a really difficult time sometimes saying kind of what these obsessive thoughts are. So with kids, sometimes great, you see them and they're doing this hand washing and, they come into your office and they have their red raw hands and it's pretty clear that something's going on. But most of the time we're not so lucky. And so the things in kids, they are having these intrusive images of maybe something horrible happening to their family or them doing something really bad, or they have these urges that they have to do something just until it feels right, or they're counting and they have to stop counting at a certain number. And all of this goes on inside their brain. And I think, depending on the age and how you ask the question, it's really hard to get to that symptom that they're having going on.
Yeah, just want to rewind for a second. I'm having kind of an insightful dumb guy moment. It really does have a relationship to where you are in development. And I mean, the things that can distress you mature with you.
Yeah. And I think certainly culturally as well, you're going to have different types of
Sure.
obsessions
Yeah.
or compulsions depending on what your, religious views are, what is, permitted or not where you're at. But
Sure.
kids also tend to have a lot more fears of like bad things happening to their parents or their family or catastrophes, right? Than
Right.
adults do.
Yeah, also I think corresponds to some extent with individuation and that sort of thing,
Yeah.
and
Yeah.
how you view the world.
Right.
Fascinating. So you mentioned before that there are often comorbid conditions, and some of those are things like ADHD and tic disorders, and those things can also look like obsessive compulsive disorder. How do you differentiate them?
Yeah, such a good question. And I mean, sometimes, right, it's time and sometimes it's asking the right questions, right? And so certainly, like we talked about with the personality disorders, I think, sometimes kids just have these like rituals that they do just that help them, right, function. And so if it's not causing dysfunction or distress, even if it seems a little bit odd, it's probably not OCD because it's not like ego dystonic like we talked about. For ADHD, really it's okay, if they're inattentive, what is going on? Like if, trying to ask like, what's going on in your brain, asking about, are you having to stop on a certain number? Are you counting? ADHD can also, with just being unable to do your homework or initiate tasks, it might be that they have to write their name perfectly in order to start the paper. And that would be OCD as opposed to ADHD with being unable to just organize and initiate things. Also, tic disorders, right, really would be sort of the motor aspect of the tic as opposed to the volitional aspect of the OCD, right? Like, but you will see kids who, if they like bump their one arm, they have to bump the other arm, or they have to like move a certain way until it feels right before they can sort of initiate their walk. And it can look a little like a tic, and sometimes they have both, right? Which is also,
Right.
hard. Yeah.
Where does nail biting fit in with all this? Or things that feel like simple habitual things?
Yeah, yeah, no, I think, nail biting, gosh, it's hard, right? I think, nail biting in some ways could be a little bit of a tick or just like a, sort of unconscious habit. It would be like the underlying reason why. Like if they're just nail biting because they're just, spaced out and they can't pay attention to it, right? That's just your like habit of nail biting. If somehow they are driven to bite their nails off because if their nails are too long, they're going to get germs and they're going to kill their grandma. That would be an OCD behavior instead.
What about coexistence of OCD and autism?
Yeah, that's a really hard one. One of the criteria of autism, right, is that you have these repetitive non-functional routines, these sort of obsessions with, very like minutia, right, or getting sort of overly preoccupied with things. Kids with autism are not distressed by these rituals, right? And so that's one of the things is it brings them a lot of joy and satisfaction and decreased anxiety to do these rituals. Whereas in OCD, it is really highly distressing and seen as pretty impairing. That said, both of them can really affect functioning, right? If you can't get your kid with autism out the door until they do their 5-step ritual of, getting their clothes on and such. I mean, it is very much aligned with kind of the dysfunction of OCD too. But it is really kind of that it is pleasing to the kids with autism versus it is pretty distressing to the kids with OCD.
Are there early warning signs that parents should be watching for, that we should be watching for?
Yeah, gosh, just being unable, like for parents, right, being unable to get out of the house because of something, right? Like if they cannot leave their room until like everything is color coded, or if they cannot walk out the doorway until they go out that doorway 3 different times, right? If it's really starting to like impact how they're able to just go about their day, I think that's something to pay attention to. And I mean, certainly as a parent, super easy to get so frustrated with that, right? It's like, come on, just go, right? And sort of take
Right,
a step
right.
back and think, why are they doing this specifically? I think for school, right, like rewriting your schoolwork, like lots of eraser marks because they have to like have it just perfectly, like not handing in work if it's not done just the right way, right? If you're finding a lot of work and you sort of ask like, why is it still in your backpack? And it's because they didn't do it the right way, like that would be a really good sign. Just a lot of like inattention and preoccupation, which maybe, I mean, most of the time, right, kids with ADHD have had it for a very long time, right?
Yeah, yeah, yeah.
Right, and OCD, it develops later on too, right? Like so if you see kind of a clear change in how your kid is doing things, that might alert you that something else is going on.
It's less likely to be a simple dawdling, and rather it's being driven to do something that causes them distress if they can't do it.
Yeah, exactly. And you can just see in their, I mean, most of the time it's just like it's so distressing to them and they just can't help themselves, right? They just can't quite walk out that door until they do the right thing.
I'm guessing that you also sometimes feel that your life would be much simpler if you had the equivalent of a nasal swab that would make the diagnosis for you.
That
Um,
would be great.
are there any new development about things that people are watching for, neuroimaging, genetic markers, anything like that that is helpful with OCD?
And, unfortunately, not really. Like they do know that OCD tends to reside in, I'm going to say this, just the corticostriato-thalamocortical circuits within the brain. And I think that's come from some functional brain imaging, but that's not anything that we can use sort of diagnostically at that point. So as much as it's very interesting, and it does give us some sort of neuropathophysiology for the OCD, it's not going to help us diagnose it. Also genetically, right? It does run in families, but there's no like genetic test that we can do. They do know that it is associated with a serotonin transporter gene is one of the sort of common associations. And then there's also they found some problems with glutamate receptor and modulating genes, but again, it's not specific enough that that's something that we can just order a genetic test and we can say, yep, you have OCD. So still our best diagnostic tool is asking questions and finding out family history for this.
Well, and especially because it's the function that's most important for us to be looking at anyway.
Yeah,
I mean,
it's true.
it's not the label, it's the being able to do something. Do you want to mention anything about the gut-brain connection?
There is, right, gut brain is kind of everywhere right now. And I feel like we'll, probably learn more over time. There's some suggestion. I did a literature search before I came today, and, there's some suggestion that perhaps there's, in some cases, some sort of alteration in your gut flora might precede your OCD. But again, that happens all the time, right? And so what does that specifically mean? So nothing hot off the press yet for that, but
You may be interested to note that even the ever quotable Anna Ehrmart, who was on last month talking about celiac disease, referred to the microbiome as the black hole of gastroenterology. So
well, good. If she thinks it's the black hole, I will not feel
she's
bad.
frustrated. We're all entitled to be. And just also in passing, although maybe we should spend a whole month on this sometime. Pandas, pans. You want to touch on that very briefly?
Yeah, it's so hard, that question, right? Because you're a pediatrician, you probably get asked about it more often than I do, but very clear association, right? Rheumatic fever with chorea at some point. And then there are times, right, where kids have strep infections and then do have an onset of like compulsions or obsessions. And is that just the timing? Is it associated with the infection itself? There's sometimes you can get some OCD symptoms after other types of autoimmune, like encephalopathies as well. I think at the end of the day, the treatment that is sort of agreed upon is basically you still treat the symptoms, right? And if, certainly if it seems like someone's encephalopathic, of course you go down that route, but right now, PANDAS and PANS is still it's still kind of a controversial diagnosis. And also, if you see symptoms that kids are having, you treat them with,
Sure.
the best treatment options that we have for OCD or whatever else that they're presenting with.
Sure, and it's safe to say if someone has strep, you should treat strep. And
Of course.
if someone has obsessive and compulsive problems, that then you try to offer help there as well.
Yeah, exactly.
Perfect. Well, this has been very enlightening. I really appreciate your time, Kristi. Anything else you want to say about the diagnosis of pediatric OCD?
Yeah. Just one other thing. Typically, this is, I think, the case for a lot of our childhood onset mental health disorders, but symptom presentation to diagnosis in kids can be as long as 2.5 years. And so I do just want people to be on high alert for, if you're seeing a kid whose function has drastically changed, even if they're not washing their hands or they can't put words to some of the obsessive thoughts that they're having, like asking a couple more questions, because the earlier we can get the diagnosis, the quicker we can get treatment on board. So
And we're going to talk a whole lot about treatment next week.
can't wait.
I can't either. This has been very enlightening. For those of you who have questions, and I know you do, send your questions to questions@vcurb.com. For those of you in the area who need more personalized help with a patient, the call-up line, we will include the information in the show notes as well as the website.
Which is callup, so callup.utah.edu.
All right, Kristi, thank you so much for your time. We'll plan to talk again next week if you're willing to come back.
Sounds great. Thanks so much, Paul.
Thanks for joining us. We look forward to getting together again next time. The Virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.